Portions of this meeting are being recorded and may end up on our website, which is right here, www.mmclibrary.com, where a lot of the content regarding this subject is contained, including a full recording of the NOAA presentation in Denver last November, if any of you want to watch that. It has a little more detailed content. So the role of silver nitrate in the management of caries in children is the topic today. So I'm a general dentist. I own Shoreview Dental, which is a private practice in the city of Kaiser, Oregon, and I'm the dental director of Oral Health Outreach, which advocates for providing access to care for our new expansion populations. Most of our references, again, can be found at this electronic library. There are literally hundreds of papers and videos and references there. I'm always looking for new stuff, so if you visit the library and you have a paper that it's not fair, or my paper's not there, or something, let me know. It's an open source library. This is the archive room at Northwestern University, where G.B. Black's original papers are located. And this, underneath G.B. Black's photo, is written in his own handwriting in about 1900, which I copied out of his handbook, How to Apply Silver Nitrate to Make It Effective. The story goes way back, more than 100 years ago. It's quite remarkable. And I've been kind of a detective, and I share a little bit of that detective story. This subject, which I'm calling the medical management of caries with silver nitrate, was first published in the California Dental Association Journal in November of 2012. So this is like the first paper in about 60 years that ever discussed this in dentistry. It's available on our website. So my story quickly is, again, I've been a dentist for 30 years, mostly practicing in public health areas, mostly interested in special needs patients. Prior to 2005, I was the dental director of the largest Medicaid provider in the state of Oregon, Capital Dental Care, which currently has close to 300,000 Medicaid lives. I had been doing that for about 10 years and was getting kind of tired of watching caries rates going up, access to care going down, and just didn't feel like I was being effective. And one day I was driving in a zip code looking for a dentist to recruit to become a Medicaid provider, and I got lost, and I decided that it was time for me to become the provider I was looking for. So fired myself, went back into private practice with a focus on Medicaid patients in the zip code that had never had a Medicaid provider, did not have a Medicaid provider at that time. And of course, I'm sure you know what happened when we opened the doors. Overwhelmed, sort of like what you're experiencing with the adult expansion right now. Okay? Everybody's trying to get in. We don't have enough resources. So that's the world I was in 2005. So I wanted to do all the right things. And I thought I knew a lot about what those things were. So this is what I did in 2005. Motivational interviewing. Okay, I took the long class. I believe in motivational interviewing. I'm not teasing you. Okay? I think it's important. Okay, education, oral hygiene, absolutely. Dietary counseling, very important. Enhanced recall schedules. I didn't care if Medicaid paid for one recall a year. In my practice, if you needed to be seen every week, that's what we did. Okay, get people in until we can control their disease. That's what I believe. Fluoride varnish, isn't it great? We put fluoride varnish on every tooth that walked through the door. We did it as many times as possible. 2005. Oh, more fluoride varnish. There we go. Okay, sealants. We talked about sealants earlier. Sealants are important. I believe that. We did sealants, we did more sealants. Then we tried betadine. We tried chlorhexidine rinses. We tried some of the antimicrobial agents that we have been experimenting before in dentistry. We visited Head Start and WIC. We did school screenings. And after a year of doing all of those things, okay, the simple reality is the most at-risk children kept coming in the door looking like this. All right? This was still going on. And so I was at a real crisis. Something had to change because using the best knowledge, I was not getting the results, or I was not reaching everyone in the community. So This was a hospital case, and when I opened the practice in 2005, I had hospital cases booked out for 3 months, okay? Had kids waiting in line to go to the OR. And we were just trying to figure out how to put the fires out until we could get them to the OR. When I took this child to the OR and I saw that it's obvious this was a return OR case, okay? And we did a little bit of research. This child had been taken to the OR 18 months earlier by a pediatric dentist in our community, gotten all of their dental disease, quote, fixed using the restorative model, okay? And here they are now, a year and a half later, it all failed. We had abscesses, etc. And so something inside just said, something's wrong here. The solution is not fitting with the problem. So in summary, my practice faced a very high disease load. I was doing all the right things, and I figured out there has to be a better way. There just has to be a better way. So I decided to dive back into the literature, look at what I was taught in dental school and go back and see how dentistry was practiced by the founding fathers. And I discovered, some wonderful literature from W.D. Miller in 1890, G.B. Black, 1908, and Percy Howe in 1917. We'll briefly go over those things. So I wanted to know how dentistry was being practiced 100 years ago. What I found was astonishing. 100 years ago, those three individuals who are probably the most important founding fathers of our profession all treated caries with the same thing. The #1 tool for treating caries at that time was silver nitrate. And so I really got interested in this old literature about silver nitrate, and I started looking at the microbiology, and I'm a microbiologist, and I have a lab in my office, and I started, gathering bugs and killing them on Petri dishes and doing all that kind of stuff, and looking at chlorhexidine next to silver nitrate and some of these other tools. And I said, okay, 100 years ago they used silver nitrate. What are we using today? Fluoride varnish. I had been painting fluoride varnish on teeth for now a year in that practice, watching the teeth continue to decay. Okay, and I'm not saying that fluoride varnish doesn't have a role, it just wasn't working for that population. There are 2 major review papers that the ABA, Council on Scientific Affairs, has issued in 2011 and recently in 2013 on non-fluoride caries prevention agents, and the more recent one on the fluoride caries prevention agents. These papers, by the way, are on the library, on the electronic library, if you want to read them. The summary is that some of these things work some of the time. None of them work very well. If they did, we wouldn't be in the middle of a caries crisis, would we? And that's the simple reality. Why do we have to have Mission of Mercy? Why do we have people waiting in line in the rain to get into the dental office? It's because we've got an out-of-control dental problem. So what I'd like to do is introduce a new concept. And this is what was developed in my practice in 2006 approximately. And that is to develop a combination therapy using the old antimicrobial approach, silver nitrate, to stop the infection in the cavity, and using fluoride varnish as well. So antimicrobial remineralization combination therapy. So let's go over some of the legalities. Can we legally do this? Well, just last weekend it was the Oregon Dental Association meeting, and one of the speakers at one of the well-attended classes pointed out that there's something new on the horizon coming. It's silver nitrate, and it's being tested in Europe. And one day it might make it here. So the word's kind of getting out there, but it isn't really understood as well as it ought to be. Okay, silver nitrate is here, it always has been here, and we're using it today very effectively. Silver nitrate can be ordered from Henry Schein. Okay, you can order it tomorrow. You have it in your office tomorrow from the largest dental supplier in the world. Where's it manufactured? Doesn't it come from some third world country where the environment is harmed? No. Silver nitrate, pharmaceutical grade silver nitrate, is manufactured by Gordon Laboratories in Philadelphia, right here. They've manufactured it for 70 years. This has been around a long, long time. we are now recommending a 50%, and I'll let Moffat talk a little bit about that, but she kind of talked me into it, and I think we both are seeing better results with really no concerns about toxicity. There's a lot of literature on this on the library. Okay. What's the FDA status of silver nitrate? That's important. The simple answer is there's no status. It has no status. So if you want to know, does the FDA approve use of silver nitrate for caries arrest? No. Okay. Does the FDA approve fluoride varnish for caries management? No. I mean, we live in a world that's kind of gray. And some of these things are used off-label, even though we're not supposed to use that terminology. I'm waiting for the new terminology, but... So the simple reality is we've treated thousands and thousands. Since 2006, thousands of patients have been treated with silver nitrate and fluoride varnish to arrest caries. It works better than anything I've ever seen in my life. Do we know exactly how to do it? How many times? How often? We're learning that. We're learning that. And Moffat will share her journey a little bit more. But the reality is it works better than anything I've ever seen in my life. So why do we need this? Well, the usual stuff isn't working, is it? I'm just curious, how many of you in this room think that there's a sort of a crisis of dental caries in our country? Is it true? Yeah, everywhere we turn. Congress is being debated. In Oregon, it's a nightmare. And it's our duty as a profession. We've been in this profession for 160 years, and we have not cured caries. So now's the time to figure it out. And I don't know that this is the perfect answer, but it's a step in the right direction. And so that's my little journey and why I'm here. And now Moffat is who you should really listen to. I'm happy to turn this over to her. Your presentation. What's in it?
Okay, so many of you went to NOAA, and many of you were here, was it August 2012, to hear Steve. So I wanted to make this presentation a little bit more informal, interactive, and so you can feel free to interrupt me, ask questions, or for clarification. I have kind of a lot of slides that some of them I'm going to go through pretty quickly. Some of this is new data that I put together yesterday. So you're getting it hot off the presses, and yeah, I think that is the introduction. Does this thing work to move slides ahead?
Yeah, you just have to be where it can read it. You may have to stand in.
Okay. I don't have any financial business interests in any dental products or in this presentation. If we do cure caries, just like you, I'll be out of a job. The acknowledgements is just that the reason why I feel like I've been able to do this is because I have admin time. A lot of dentists don't. And because I, as a dental director, have more freedom to figure out how do I want to treat patients. I can use the best available evidence. It's not what I was taught in school, so that's a concern. But the people who made it possible, Steve, obviously, I would have had no idea about silver nitrate. Dee Robertson has also helped a lot in trying to frame how to collect the data and how do you do it systematically, locally in my public health system. Peg Turk, who's a hygienist, works for the oral health team, has been extremely helpful, keeping me honest, keeping me collecting data in a way that we can learn something from. She works with me every Monday. It was quite a commitment. Every Monday for the last year and a half. I see patients on Mondays. She comes to the clinic, does her work from there, and then helps. John Bennett, the dental director, is amazing. He can, so he's also been involved from the beginning in making it work. I started using silver nitrate first, and then the other dentists in the clinic, in our one Columbia City clinic, have also adopted it, and I really, really need to thank them for trusting me and for moving forward with using a technique that they hadn't been familiar with, and I'm very happy to say they love it as much as I do. They've done a lot of patients since they work full time.
Martha,
Yeah.
where did you get your PhD on?
Thank you. I have a PhD from the Department of Pathobiology. It was in molecular biology, so there's some relation, mostly to my ability to tolerate data in spreadsheets. That's what I learned in graduate school. So this Dee Robertson and Steve connected a while ago. I don't know if it was maybe 2008 or 9, or I don't know, and have worked together well ever since. I think there's many people who deal with very high-risk kids who have seen, the physicians recognize that the main problem in their 3-year-olds is decay. Whenever we go to third world countries, I recently went to Guatemala, the kids' main problem, their health problem, is decay. So there's a lot of people who are interested in this, who feel sort of powerless. I think Dee really took it on as an Indian Health Service pediatrician to not just say, that's a problem, maybe you should go to the dentist, but try to figure out, in Dee's way, is he smart enough to figure out something that nobody else knows? He hooked up with Steve, and it's quite like the Three Stooges between the three of us. We're in constant communication. It's exciting, but we're starting to feel like family, or we're starting to fight. Anyway, in a good-natured way. So just like everyone here, how we treat cavities, how we approach high-risk kids is a really strong focus on diet. I think diet's the most important element that we can change. And fluoride varnish, sealants, of course, we do all of that in spades. They still have cavities when they first come to see us. They have cavities, and then they continue to get cavities when they're babies, or by the time you take interproximal, take X-rays to see the interproximal. Most kids need to come back for restorative work. It's just like the population of kids that you're treating. The usual patterns is the babies have aggressive decay on their upper anteriors, and then get occlusals on the molars, and then when you take x-rays, they have interproximal decay at age 4 to 7. Even the kids who come to the clinic regularly, I do not feel confident in general in my ability to stop the disease by counseling or fluoride varnish, or I don't know. So far, my success, while I don't have numbers, is not. It's too low. And the way that I've been treating these kids, my friend, treating anterior baby teeth, a lot of failures. Those restorations last less long than the teeth. So I'm having to redo anterior composites if they come in, at 4 years old. They come back, filling's gone. So I've been constantly frustrated by not only not stopping the disease, but the way I fix it isn't really definitive either. So I tried everything. I tried compressible composite, flowable, contour, glass ionomer, and opening the contacts. They all don't work. I've gone to the one that I'm best at with wiggly kids, which is compressible composite. So that's just an aside. And I define failure, which I don't know if you guys can see here, but as the need to treat a tooth again due to material failure or recurrent decay or newly decayed surfaces. Basically, if I look through the chart and I'm either retreating that quadrant or that tooth, I feel like, what happened? Is there a way to do this better? In primary molars, they're easier to fix for more definitive lengths of time, but what I ended up doing is for young kids with aggressive decay, I had good success that I could handle only with stainless steel crowns. Fuji triage, composite, amalgam, all had a rate of failure that was not subtle. Like I would regularly see fillings with recurrent decay. I would regularly see fillings that broke. So I went to stainless steel crowns. And so I tried a bunch of techniques to figure it out. I also tried very similar, independent, but very similar to Steve, that just, okay, well maybe we need more fluoride and it's got to be varnished. Maybe chlorhexidine, I got excited about that for 6 or 8 months, and then iodine, again 6 or 8 months, but didn't see any kind of, I wasn't tracking data, but I wanted to see a real impact, and if it was reasonably effective, I would have seen something. And then, so I went to, if the kids are really young, rather than going straight to crowns or doing fillings that I knew wouldn't last until the teeth came out, I did Fuji triage on all the occlusals. Krista Lucky actually, somebody I went to watch to see if there's another way to do it, and he recommended Fuji triage on occlusals. So those are the options. Fuji triage on occlusals is nice because you don't have to do restorative, but it didn't definitively stop the disease. I often was doing crowning teeth that had been treated with Fuji triage because of interproximal decay or loss of the Fuji triage or recurrent decay. I don't know if it's just me, but I suspect that a lot of you also have little kids who continue to have problems from the start. So I learned, like you, in August 2012, that there was something else I could try. I had tried enough things that I was like, okay, I don't have anything to lose. And so in October, I finally got it together enough to order the silver nitrate, the supplies. It was very easy, but it took me a few months to get going. And then I tried the front teeth first so that I could see, if I could tell what was going on. So I treated the anterior teeth first, and picked some cases where I was like, I know if I try to put a filling on this rotting baby tooth, it's going to come out. So I really felt good about the decision to try it. And then I saw immediately, it was very, very satisfying, that if you put silver nitrate on rotting anterior baby teeth, the decayed part of the tooth turns black. And a week later, it looks fantastic. Okay, so I started using it with anterior teeth. You have to learn to judge what's a rest. I was like, hey Steve, the cavity turned black. Is that arrested? What is that? You know, so I just had to gradually, just like any kind of technique sensitive thing, get comfortable with when is it arrested. So after I did anteriors, I moved to occlusals. It's just a little bit harder with 3 and 4-year-olds to keep the occlusals, to apply silver nitrate in isolation, with isolation and occlusals, but also quite relatively easy compared to doing anything else in a 3 and 4-year-old. After seeing the occlusals arrest, then I tried to do interproximals. And interproximals remain the toughest to get the silver nitrate into. And so far, then all the dentists in the clinic, so all our patients had the option of silver nitrate starting in May 2013, ramping up after a few months. The other dentists got hooked and pretty much had the same approach as I did after seeing it work for a couple months. And so far, at least 688 kids at the Columbia City Clinic have had at least one silver nitrate treatment. So it's a database that's growing fairly rapidly. What's the protocol? So at the first visit, it's pretty common that we don't do the silver nitrate treatment at the first visit. We focus on the regular stuff for a high-risk kid. We have them come back during their second visit and apply fluoride varnish and a silver nitrate and fluoride varnish, and then tell them to come back in a week. Then come back. So they get 3 applications. The first one, and then a week later the second, and a week later the third. Patients who have had problems, or I can tell, I don't know, I think I know that the cavity's not arrested, I'll have them come back again. But our general protocol is 3 applications 1 week apart. And for the vast majority of visible cavities, that's if not overkill, enough. Interproximals, I'm still learning. Oh, that's not what I meant to. Oh, nice. You can watch me from sideways. I have no idea why that happened. All right, so I don't know if you can see it. I've played a couple times. You have to watch really fast because I'm treating a tooth right there, and that's the silver nitrate. Getting paranoid about making sure it's on the grooves, and then that's the fluoride varnish that I'm. Oh, I already put it on. Okay, let me show you one more time, and I sorry, it's going sideways. So that's the silver nitrate. I already put it on. That's the fluoride varnish. So I'm trying to just layer it over the silver nitrate treated tooth. I mean, the point of the video is just to say that if you have a cooperative patient like that, you still need isolation. You still need to like get all set up, but it takes a few seconds for the tooth. It's painless, easy. If you're a dentist, you're paranoid about everything, so I'm also paranoid about making sure that there's no saliva or plaque on the teeth that I'm treating to try to get maximal penetration into the grooves or wherever the cavity is. Interproximals are the technique's tougher. I use a stimulant in between the teeth and try to soak the silver nitrate in between it, add it in, and then cover it with fluoride varnish all the way from the buccal to the lingual to seal it in. So what I was happy about is that arrest, if you can get the silver nitrate onto the lesion, it works. Arrest for the front teeth was similar to the occlusals. Arrest of interproximal decay is more difficult to assess, right? So sometimes I can only do it based on x-rays taken 6 months apart, which if you have 2 sets of x-rays and you're trying to say, did that lesion get any bigger or not, it's hard. Also, sometimes I start out without x-rays because the kid isn't taking x-rays yet, and then the second visit I get x-rays. So it's a 6-month call on interproximals is very difficult for me. But arrest seems to be generally independent of changes in oral hygiene and diet. So I know some of these kids have not stopped drinking juice or not all of a sudden become perfect patients. And it still works for them. And after arrest, I sometimes do restorations. Like I could put some glass ionomer in there. But in general, I only do it for the front baby teeth, and that's because I want to satisfy the parents and their teachers or their nurses that the kids are, just aesthetically. And I would say I only do that maybe 20% of the time at the parent's request or because I can tell they're nervous about it. There's a consent form we use. So far, nobody has not signed it. You have to tell them this cavity will turn dark. When the cavity dies, it's going to turn dark. So that's the main thing that they will notice. Most likely the same day that you treat them. This is the form that I use to collect data. Basically, I do check boxes on where the cavities are and which surfaces are treated. I do when we did the exam, what's the date of the first treatment, second, third, fourth. If we do a 6-month exam or a 1-year exam. So it's you have to be meticulous with data, and you have to have everybody on board to be able to consistently get each patient's data updated. So I'll show you the data now. The caveats to the data are that all the data is for primary teeth. It's based on patients who had at least 1 silver nitrate treatment, which means some of these patients only have 1 silver nitrate treatment. It's very common that patients did not return for all 3 recommended treatments or did not return for the evaluation. Like maybe they came at 1 to 3 months but didn't come back for 6 months. Maybe they only showed up after a year. So even if they had 1 treatment and they showed up after a year, I included that data. So this is new data. I'll give more caveats as I describe it. Patients whose decay was not visibly arrested, after 3 treatments, I always asked them to come back for additional treatments. It was very rare that I did that, but wanted you to know that there was a lot of variation in the number of treatments that people got in this sample. It's not research. It's my attempt to arrest cavities as a dentist. And so if I thought it wasn't arrested, I just kept treating it if they came back. Typical treatment protocol is 3 applications, 1 week apart. So here are just the number of kids and teeth and surfaces that were treated. Of the 688 kids who had at least 1 treatment, we treated 2,600, 2,700 teeth and 3,500 surfaces in those kids. About 300 we were able to assess were those lesions arrested, like initial arrest at 1 to 3 months. We assessed 1,200 teeth, 1,600 surfaces. For kids who came back after 6 months, there were 92 of those kids with 334 treated teeth with 477 treated surfaces. 1 year, we're just starting to kind of trickle into. We have 16 patients so far after a year. We treated 86 of those teeth with 111 surfaces. No questions on that, but basically it's just who was in the data set. At 6 months, the outcome is, so of the 92 kids who we saw after 6 months, we treated 334 teeth, 477 surfaces. At 6 months, 88% of those surfaces were arrested, and 85% of the teeth. So I feel like this is nothing like fluorides, nothing like iodine chlorhexidine. I feel very good that 88% of those surfaces were arrested.
Is that by subjective assessment?
Yes. Yeah. There is no other assessment for it. Yes. It's the lesion stayed black, isn't soft, and isn't growing. So it's, yeah. So what about, so 88% arrested, can you tell, can I say anything about the 12% that didn't arrest? What were they like? Why didn't they arrest? To get at that, I basically wanted to see what I already had a sense of, that interproximals are both harder to arrest and harder to confidently score as arrested. So often when kids came in with interproximal cavities, they came back 6 months later, I wasn't willing to say, oh, that's arrested. I'm not going to score it as arrested. I'm just going to say, we'll treat it again and see you in 6 months, and then I'll have a better sense when I take another set of x-rays whether or not it's arrested. So of the interproximal, this is 6-month data for interproximals versus visible. Okay, I didn't put a slide up this, but you should listen to this definition. Posterior interproximal means mesial and distal surfaces of the molars, the primary molars. Everything else is visible. Visible is all the anterior decay and the occlusals of all the teeth. Okay, so basically posterior interproximal is only baby teeth, mesial and distal surfaces. At 6 months, we treated 112 of those baby teeth interproximal molar surfaces. 65 of them, I was able to say, okay, that's arrested. The rest of them, I either couldn't say or I felt like they weren't arrested. I don't have that data called out yet. So I was only seeing 58% at 6 months that I was confident enough to call arrest. Okay. The visible decay, all the rest of the decay, the 365 surfaces, I'm getting very, very good arrest at. So it's really the interproximals that are making me, I have to wait longer to figure it out. I don't know how effective it is. I'm working on optimizing the technique. But if you can see a cavity on a baby tooth, put silver nitrate on it. Some of these were treated once, some twice, some 3 times. 97% of that. Here's the 1 year of the same data, so hopefully this will be a little easier to understand the second time around. Evaluation of treated surfaces. So the total, as you might remember, at 1 year was, no, this is the first time you've seen it. At 1 year, the total arrest was 84% of treated surfaces. The posterior arrest was 61%, very similar, 58% of at the 6 months. And the visible decay went down a bit from 97% to 92% at a year. So maybe just more opportunities to see the kids after a year. I have to look at these sort of failures to figure out, I'd love to get that number to like 99%. And I think if we knew enough about how to apply it and when to not be a hero and actually just do a pulp and crown, then we might get that number up to very, very, very high. I'm pretty happy with 92%. Okay, so don't get me wrong. I just want to optimize now. 1 year outcome data. Okay, so treated surfaces not scored as arrested at 1 year and new cavities at 1 year. There was only 16 kids so far with 111 surfaces that were treated at least once, 31 new carious surfaces after a year. So of these 111, 111 were evaluated, 18 surfaces were treated at least once, but not scored as arrested. Okay, this is all making sense. 84%, 16%, 18 surfaces. 11 of those were interproximal. At 1 year, I could not score 11 interproximal surfaces as arrested. And again, do I have x-rays to compare it to? Maybe, maybe not. I'm not going to call it arrested if I don't have a comparable set of x-rays. So these, there's a story behind those 11 surfaces that I don't know the answer to. 7 were visible. So at a year, there were 7 visible surfaces treated that were not scored as arrested at 1 year. Some of those are very likely to be failures. So I want to say that too. I can't explain away everything to 100%. I do have a handful of failures, 3 or 4 that I remember. Like in a whole mouth of decay, I can remember that tooth did not succeed. I treated it 3 times. I thought it was going to work, and it failed. So I want to be honest and say this doesn't work all the time, every time. The failures are on deep decay in general. Newly identified cavities, there were 31 new carious surfaces, almost 70% were interproximal, and 10 were visible. Here is October 12 to October 13, the number of stainless steel crowns per month. As I said, I have really good success. We all have probably good success with stainless steel crowns. I had been using those in lieu of retreating teeth. I changed that practice and was able to, using, instead of an operative approach, use a preventative arresting approach to get stainless steel crowns from about, on average, I would say we did about 75 crowns a month at Columbia Clinic for a couple years, maybe 5, 6 years. And then right now, we are doing 5 or 6. And that's, so I looked at October. Since then, it's been 5 or 6 for November, December, January, February. So we've had a huge success in not having to crown a lot of our kids' teeth. I felt very good about that. This is the raw numbers again. It was like 11:30, so I'm sure this is not a good idea to put all these numbers up here, but I made that decision. That the number of stainless steel crowns. October is when I started. I didn't. This is for all the kids in the clinic. I was working 1 day a week, so some caveats here. We were doing a variable number of crowns before that. I'm averaging it out to about 75. So these lines are months from July 2012 to February 14. This is the total number of restorative procedures that we did each month. This is the number of stainless steel crowns we did each month. This is all patients at that clinic combined. I am like the most minor one dentist because I only work there 1 day a week. Starting around May is when the other dentists really began using it, and by like July, August, they were really using it as a very serious option. So the most obvious thing is that stainless steel crowns dropped dramatically when we all started using silver nitrate, which was starting around May. And you can see 6.3, 6.5. We're not doing many stainless steel crowns, and those are usually pulp and crowns where they come to us with, there's no other way. And this is overall restorative, and this is for 0 to 20-year-olds. Overall restorative procedures done for 0 to 25-year-olds. It's 20-year-olds. So we were doing around 300 on average, and it has dropped since the other dentists who work there often have used it from 300 to about, I don't know, I want to say like 150. So we used to do a lot of stainless steel crowns. A lot of this drop is particular to the stainless steel crown drop. But overall, you could see that we have to do less restorative by introducing silver nitrate as an option for kids in this clinic. Yeah, so obviously, it's working for us. I call it a win-win-win approach because I like it, the staff like it, the assistants love it, the kids are not crying. It's much easier on the staff. The next win I would say is the parents. You know, you don't need to do a filling, you don't need to give them a shot. The parents are not, in general, like by the vast majority of parents are not, they don't come back at you as, oh, you have a medicine that can stop the cavity. They don't say, no, I'd rather have a filling because it's white. They say, oh my God, thank you. It's like, if you could just put the medicine on, yeah, let's do that. So that's the win for the staff, the win for the parents and the kids. You know, I'm treating the younger siblings of kids who have full mouth of crowns, and they're like, oh, why are you're not doing the crown right now? What the, oh man, is this new? Yeah, sorry. So after starting to use silver nitrate, I do far fewer of the Fuji triage on all the kind of vaguely rotting occlusals. I do less operative. The clinic as a general does less operative and less stainless steel crowns. Kids, parents, and me representing the staff really like it. Our kids are much easier to manage.
I have a question.
Sure.
So did you say that when you apply the silver nitrate, the tooth does turn black at the
Just
front?
the cavity,
The cavity
it turns
itself.
black. The enamel is shiny white, but anywhere where there's a cavity, where it used to be kind of a leathery almost look, that turns black.
Okay.
And I'll show you some pictures.
And does the parents, I'm saying, you mentioned something about the aesthetics, or
Yep.
so you cover that, or do the kids talk
I
about
would
the teeth
say-
being black?
I don't know what percent, I should look at that, but for kids it's on their front anterior baby teeth. If we turn the portions that are rotten black, there is some number of those that we take out the black and put in fillings, white fillings, because of aesthetics only. So we have that as an option, which just having it as an option is really helpful, I have to say, but we don't have to use that option very often. Yeah.
I can't remember if you said you applied the decalcification as well, and if you do, does that change color?
I've gotten more happy to apply to more surfaces over time, including decalcification. It acts just like a caries indicator. Sometimes the decalcification turns gray. Sometimes it turns black. Sometimes it has a stain on top that you can polish off after 3 months. So it varies. It's kind of an interesting, it's almost like a diagnostic tool for me now. Like, what was that decalcification? It does change the color. So if you are worried about front teeth and they're just really weak, you have to decide: are you be okay possibly turning it dark or not? I'm very happy to, especially on 3-year-olds. I just don't want the disease to take off. So I'm very happy to apply it on those surfaces. Now, it took me about 6 months before I was comfortable including those surfaces. So the main benefit, of course, is that you're stopping the disease with using a topical antibiotic, kind of what we had hoped for fluoride, you're arresting the cavities. The additional pluses, of course, lessen the need for young kids to go to that operating room, less restorative work, relatively simple technique, and you can see a lot of patients if you're doing those fairly quick procedures, so I like that too. I'm going to do these questions, just show you how there's some things we don't know that we want to know. It'll take probably 2 more years to answer these well. But we don't know the exact long-term reduction in the need for restorations, right? We dipped it way down. How many of those teeth are going to stay arrested for the lifetime of the baby tooth? I'm not sure. Which gets to the optimal intervals between treatments. Right now I'm doing them as soon as I can get them back. Basically, within a week later is what I asked them to come back for, hoping that most people will come back. Knowing that if I say 3 months, I tried 3-month exams. I don't know how many of this aggressive decay, I don't know how many have tried 3-month exams. Our rate of return of 3-month exams is very low. Duration of caries arrest, effectiveness. Does effectiveness of silver nitrate treatment vary between primary and permanent teeth, or smooth surface, pit and fissure, and interproximal? Initial data possibly indicate that interproximal, probably because the technique is harder, is less effective. What's the optimal number of applications and optimal technique for application? Do other treatments, like after you arrest a lesion, packing in some gloss ionomer, does that help? Does that matter? Should we do it? I don't know the answers yet. Thank you. Those are my kids. I don't know if you've seen that picture yet. He's 6, she's 11, and he knocked his front teeth out, so typical dentist kid trouble. Just to show you what it looks like, these are really like very satisfying. Maybe this kid's 5, I don't know, 4 or 5. Very satisfying. Rather than doing kind of Fuji triage occlusals on the occlusals, I just treat this with silver nitrate. In these types of cavities, silver nitrate is super effective. Like I'm confident that is arrested. This is what I'm talking about for aesthetics. It looks like I had tried to fix that tooth and that tooth before. You can kind of see it's carved out a little bit. And then it decayed some more. And these two I hadn't treated before, but now they're decayed. So when you put the silver nitrate on the surfaces, it acts like a caries detector. That enamel is okay, but the decay turns dark. This looks like it didn't, I put a filling in here, but that wasn't carious, so just here, either I didn't take out all the decay when I fixed the tooth maybe a year before that, or it started rotting again. Here's a case where the front 2 teeth were so bad we took them out maybe like 6 months before this picture, I'm not really sure. And these 2 teeth had tried to get restored, but either the fillings came out or whatever. There's decay. We applied silver nitrate there and just put composite. That's compressible composite, which I have the most, but it's just easiest for me to use technique-wise. So you can, in answer to the aesthetic question, you can definitely take out the black. You can't put a white filling over the black and expect it to not look like really, like you just slap it on top. So you have to, like with a round burr, take out the black. It peels out really nicely. Underneath that is a very nice tooth surface, which I think somebody heard me mention before. When I really understood what caries arrest was taking out the black out of the cavity. Then I could see that there was a very nice dentin underneath the black. Whatever was black came out, and the tooth underneath was nice. It was like a regular dentin, which I had been used to being paranoid about going too deep into baby teeth. So I never knew quite when to stop. This, I could stop, and I could stop confidently. Some of the teeth that I thought I was going to pulp after I treated silver nitrate, when I took out the black, the portion that was mushy, didn't need a pulp treatment because I could tell that dentin was just hard. Here's what it looks like. Got some saliva on the teeth, so it's a little harder to see, but it's very satisfying also to not try to fix this cavity. I just had to put the medicine on. And it kind of does that, carries detector slash arrestor to these teeth. That's a very nicely arrested surface. This kid, remember, just because her mom did change habits a lot when she was little, she all of a sudden got like all of her AJ, K, and T had this look to them where they had buckle decay and bad grooves, and then nothing else happened. I can't completely explain it, but mom was very actively worried about the teeth. And so this was a nice one. Instead of crowning it, because it wasn't even that deep, it was just everywhere where I would normally like be pretty happy with a crown. Instead of doing that, I could just paint on the silver nitrate, and that stayed arrested. Okay, this is like a confession. Kids move sometimes when you put them on, so I like to really control their movement. For her, she would close her mouth as I was putting it on, so the micro brush, like on both sides on the bottom, touched her lip as she was closing her mouth, and I was trying to get it out. So that's staining. Mom brought her back and said, "What the heck?" Like an hour later. You can usually, if you look, you can usually see that it's going to stain, but it gets darker over a little time. And then I said, well, why don't we see her a week back for the next treatment? And that's her a week later. I don't know how, she said it took about 3 days before it went away, but it depends on the type of skin. I think lip would go away a little faster. I've gotten it on my skin, and it takes, on your fingernail, it takes even longer, but be careful with it. Only because it stains. I think initially there was more discussion of the causticness of it. Silver nitrate, you may have heard, like if you put it on a swab, somebody's nose is bleeding, it's caustic enough that it's used to stop nosebleeds. So I don't want to leave you with the impression that it's, water. It's not. But I've never had anyone say they could feel it. When I had it spill, I couldn't feel that it was on my skin. So it is caustic by nature. I use the 50% solution. I never have seen the gums turn dark, but the skin, the lips will. The inside of the lip, not really, but right as soon as it gets dry, yes. Okay, it'll stain the crap out of everything around. If you drop a drip, it's clear, right? And you wipe off the counter, you will see exactly where that drop spread. Super, super important that your assistants be paranoid about stain. But as far as safety goes, I haven't had any indication, and I'm looking for it, that there's any level of like stingingness or damage. So far, that's not happening at all. So this is just a treatment decision. This tooth, I decided to treat with silver nitrate. This one, I don't even know if you can see it, but the decay is really soft and deep. So I pulp and crowned this one and did the silver nitrate treatment. So just to tell you, there are cases that I have decided if I think it really needs a pulp, I'm going to do a pulp and crown. Here's another one. I put silver nitrate on here, because you can do it really easy. It was during an exam visit. But am I confident that I will not have to restore this tooth? Not really. So those are, I don't know if you're interested in my treatment planning, paranoia like problems, but that's a tooth that I'll probably pulp and crown because I am nervous that it's already very deep. Okay, I think that's it. All right, so you did a good job of